Good morning, everyone. I'm Shubhika Srivastava, the Chief of Cardiology, and in the NIH investigator world, pretty junior. I would like to thank everybody who's helped me prepare for this grant and is helping me with this project. My project is titled Development of a Risk Stratification Tool to Identify the Role of Cardiovascular Involvement in Children and Young Adults following SARS-CoV-2 infection and/or exposure. Our research team, my mentors include Carol Prospero, who's our research manager, Susan McCann, as most of you know, at Nemours is our data analyst expert. Julie Coward is from University of Delaware. Dr. Wu is from Delaware. Zubair Hussain is a Bird Nemours Christiana statistician. Dr. Akins is my mentor from UD and Nemours, and Dr. Claudine Jerkowitz is my senior mentor from Christiana. So this is our first endeavor in collaboration between Nemours, UD, and Christiana. And I must say I have had like a phenomenal team that has helped me put this project and grant forward. My specific aim was to identify the characteristics of children and young adults between 10 and 30 years of age who would need additional cardiovascular care or evaluation and test positive for COVID. So this included patients who were PCR positive and can develop cardiac involvement. And our hypothesis was that there would be a difference in prior medical history, sociodemographics, clinical and biological presentations that would help identify patients and population at risk in this age group. The outcome variables that we would assess to assess cardiac involvement would be hospitalizations for a cardiac problem and multiple testing requests. And our sub-aim was to identify resource utilization in those who tested positive for troponins and BNP compared to those who did not. Now, the database that we are using for this is the National COVID database, or the N3C database. After I got the project approved and the IRB approved, we also had to get approval from the National COVID database in N3C and go through a peer review process through there and become part of a couple of domains to interact with the personnel within the enclave and the domain leads within the enclave. So our second aim was to then identify the characteristics of those who developed delayed long-term de novo cardiac problems and had no cardiovascular involvement in the acute phase of the infection. And de novo cardiac outcomes would include tests and cardiology follow-up visits, and we would use machine learning techniques to identify the most relevant associations among all the risk factors. And outcome variables would include, again, as I mentioned earlier, because this is from the N3C database enclave, and the data entered is basically CPT and billing codes, and some amount of results, but it's more order utilization and admission data, both in and out patients. So the outcome variables would include hospitalizations and, if available, abnormal blood test results. And our sub-aim was to identify resource utilization in those who tested positive for troponins and BNP. So this is using the N3C database enclave, and our timeline was that after we got the grant approval in late January of this year, we had also got the IRB approval. We sought approval from the enclave, and through March and April have started working within the enclave. Our plan is to submit for an abstract to the American Heart, just with descriptive results based on our study population. For the initial review, we are piloting only patients less than 21 years of age. the exposure variables that we would be looking at would be the socio-demographic factors and pre-existing conditions. That would include the date of the test, the socio-demographic factors, also including the zip codes, pair types, and impact of vaccine status and comorbidities. So what do I do want to illustrate is for those who have worked with large databases that include data that is derived from CPT codes, from order sets, and discharge and admission diagnosis ICD-10 codes. We have to identify what we call like large data sets or create concept models, because this is self-reported data from 73 institutions, 73 sites that goes into this N3C database. So we have to make for the comorbidities and for all the outcome measures, we are in the process of identifying concept sets within the enclave. The outcome variables would include concept sets and any ICD-10 codes or CPT codes that would look at all the tests ordered and the frequency of tests ordered and the time the tests were ordered from when the patient was tested positive with the for COVID. The outpatient encounters, we would look for order sets that utilized hospital order sets for all the tests. So our current progress since we started has actually been amazing because of the phenomenal team that is working on this. We've been working on concept sets. We have been working with the main cardiovascular domain team and seeing how we can work with what they have and build on that within the enclave. And so far, we have submitted for the reports for the concept data sets, and we submitted the requests. Within the enclave, there is a delay, so I will not be able to share the preliminary data with you for the specific data that we requested. We are still waiting for that, but I can share with you briefly what the data could look like based on what I'm sharing with you here is the public use data that is available to all from the enclave. So there are 73 sites within the enclave with 13.5 million of persons represented, and you could see with up to 5 million positivity rate. And you can see the number of clinical observations posted in the enclave is 1.2 billion with 6.5 billion lab result rows, with over 2.2 billion medical records entered. So this is like at 753.8 million visit types. For looking specifically for children, this is the data released until February 11, 2022. You could look at the geographic distribution of children. This is the age of 21 and under. And you could see that the figures over here show the geographic distribution of all children and on the left and hospitalized children on the right who had positive tests for SARS-CoV-2 who are in the N3C database enclave. The shading intensity in the states corresponds to the number of included children from each site in the United States. So it's a representative of the sample that's reported. It's not the true representation of every physical being in the United States. The pediatric data over here on the left compared to the adult data, you can see the temporal distribution based on disease severity. These figures show the relative distribution of maximum clinical severity for each patient with a positive test by month during the study period. children versus adult. The clinical severity is according to the World Health Organization Clinical Progress Scale scorecard, with red looking at hospital mortality and need for either discharge to hospice or need for invasive ventilation, vasoactive inotropic support, or extracorporeal membrane oxygenation. So this would also be part of our study outcome variable in all the children who have SARS-CoV-2 and have cardiac involvement, as I mentioned earlier, based on the CPT and ICD-10 codes. So as you could see, this is overall, this is not cardiac specific. As I mentioned earlier, we are waiting for cardiac specific data and reports, which I could present as a follow-up later on, which we will be submitting to AHA. And you can see the temporal trends, that the mortality in children and the severity of illness has decreased from March of 2020 to February of 2022, and a similar trend in adults. In terms of vasoactive and mechanical ventilation use, that has been somewhat constant. If you can see across the temporal trends over here. Another additional, I thought, information that would be probably interesting to some of the investigators is the influence of other viral infections and on the study population and need for hospitalizations. So if you had multiple viral infections on top of COVID with either RSV or influenza, you can see the blue, the influenza rates are higher for those non-hospitalized and hospitalized patients if they have it on top of COVID, but RSV is slightly higher and peaked in the fall of last year compared to the onset of COVID infection in 2020. So the next steps, as I mentioned, is to get data that's specific to us, and we are working within the enclave. And I could present that data at a later date once we get access to it. And at this point, I'm open to any questions, and I want to really thank my team that's really helping me work on this project.